This wraps up our EKG chapter. So you may be celebrating a little bit as you listen to my final lecture from our textbook where we are looking at ischemia. So this is my most exciting lecture, not only because it's our last one in EKGs, but because ischemia is really the nuts and bolts of why we even do EKG screening, especially in a cardiac rehab setting. So ischemia and infarct are important elements. You may want to listen to this recording twice or again or slow it down and stop as we go along. We're going to look at what is the difference between the word infarction and ischemia. They're two different I's. They have two different words. They mean two different definitions. Describe changes that we should expect with somebody who has ischemia, myocardial ischemia. Discuss ECG changes when we look at different phases of the infarction. Identify changes dependent on the location of infarction or ischemia, understand changes that we see that can mimic. What are other things that can happen that mimic or pretend or maybe look similar to infarction? And then describe myocardial ischemia patterns that we end up being able to realize during an exercise test. So myocardial ischemia occurs when the cells are simply just not well perfused. They're not getting the blood flow they need. So inadequate perfusion of blood, not enough oxygen, not enough fuel to meet their cellular demands. That's what the word ischemia means, right? Lack of oxygenated blood flow. Prolonged ischemia ends up really becoming problematic. So what happens is prolonged mismatches between supply and demand is what ends up being causing someone to be ischemic. So extended ischemia over time, the more time someone's ischemic, it can increase the risk and lead to what we call infarction. The symptoms of both ischemia and infarction are usually chest discomfort. You know that is angina, so tightness, pressure, pain that radiates up into the upper extremities, down the back, shoulders, neck, or jaw, increased pain with activity. I always say anywhere from the waist and up. It can be substernal chest pain. It can radiate down the left or the right arms. It can feel between the scapulas, the shoulder blades. People can feel like they have backache. It can radiate up the neck and cause what we feel can sometimes be described as tooth pain. So chronic type 2 diabetics oftentimes have the neck and jaw pain without chest pain. And really dangerous and important for you to know is that many diabetics can have no pain at all. Right, because they're suffering from such bad neuropathy from their diabetes. Neuropathy, not just fingers and toes neuropathy, but they can have what we call autonomic neuropathy. So the central nervous system is not communicating. That autonomic nervous system says, hey, diabetic person, you're not getting enough blood flow, you're ischemic, but that autonomic neuropathy is not producing that chest pain. Okay, so what we see with ischemia is ST elevation or ST depression. So ST elevation usually is what we call a transmural wall ischemia. So the lead location of the EKG changes are going to correlate with the area in the heart that's ischemic. So what this means is that you see ST elevation, so the ST segment is up above the baseline, elevation of the ST segment, and it's usually going to be in the same ECG leads, right? We have those different leads, right? 12 leads. Those leads are going to represent the area of the heart of where the blockage is, where the ischemia is. With ST depression, opposite happens, that ST segment depresses down below that baseline, and we call this a subendocardial ischemia. So the transmural is usually big and wide, the thickness of the wall of the myocardium. Subendocardial is what it's, right? Subendocardial. Lead location really does not correlate with exactly the location. So we can have ST elevation, you know that is a transmural, a big thick ischemia, or ST depression, subendocardial. Now, with myocardial ischemia at rest, so you're doing someone's resting EKG, as long as they don't have a left bundle branch block or left ventricular hypertrophy. This is what we're going to look at. So new ST elevation at the J point and two continuous leads with cutoff points are either greater than 2 millimeters in men or 1.5 millimeters in women in leads that are not V2 and V3, right? Because V2 and V3, not those. Or you can have greater than 1 millimeter in the other leads without any type of reciprocal changes. If we've got new horizontal or downsloping ST segment depression greater than 0.5 millimeters into continuous leads, that as well can be concerning for myocardial ischemia. So this is what ST segment should look like. So you see this red line, this is what we call the baseline. So that ST segment is the same as the P, right? A normal ST segment is what we call isoelectric. So right here, so we got Q, R, S, and the T is that flat line. So that's parallel, it's isoelectric, it's healthy, it's good. Right, so that is a good looking ST segment. Now look at this photo. This is showing you upsloping, right, ST segment depression, upsloping ST segment depression. Here it is with a line through it to help your eyes. So this is an EKG strip that has flat ST segment. It's depressed below that line, right, that isoelectric line. So that is what we call ST segment depression. Here's an example of a 12 lead with what we call downsloping ST segment depression. And if you look closely in V1, right, no, it's V1, sorry, Roman numeral 1 up here, 1, 2, this lead 2, and then we look at AVF and we look down here at V6. We can see pretty evident ST segment depression. Here is 12 lead EKG with ST elevation and early repolarization. So what you're looking at, you see that ST segment is elevated, right? So you see that elevated. It's not isoelectric with that P wave. This is what it looks like, a little bit more blown up for your eyes, so you're not looking at that red, pink paper. But this again is ST segment elevation. That ST segment is pressed up, right? ST segment elevation. So baseline EKG patterns that complicate. Okay, so so we have ST segment depression, we have ST segment elevation, right? So you kind of understand the differences between those two, right? So when you think about ST segment elevation, transmural, wall ischemia, ST segment depression is a subendocardial, right? And I showed you the difference of what those look like. ST segment depression, here's ST segment elevation. Okay, now let's take a look at patterns that make this all more complicated. As if just understanding this isn't complicated enough, we want to look at other things that can mimic and make you go a little confused and say, help, I'm not too sure what I'm reading on this EKG. One is called ventricular pre-excitement, otherwise known as Wolff-Parkinson-White pattern. Another one is called ventricular pace rhythm. The other is the left bundle branch block, which we've already looked at in this class. We've got greater than 1 millimeter ST depression at rest. We have someone who's on a medicine called digoxin. That's an oral medicine called digoxin that's used with associated ST segment and T-wave abnormalities. Or we can have someone with LVH, left ventricular hypertrophy. Left ventricular hypertrophy with electrolyte problems, which we call hypokalemia, and that is going to show us ST segments and T-wave abnormalities. All of these can mimic, and we may look at any of these and say, oh my gosh, we're showing signs of ischemia, but it's not. So it's just other things that can mimic ischemia that might not be. Okay, phases of myocardial infarction, changes on resting ECG is non-ST segment elevation, so we call that a non-STEMI. So non-STEMI is ST segment elevation that is typical of subendocardial damage, ST segment depression. ST segment elevation myocardial infarction, that's called a STEMI, right? So ST segment elevation myocardial infarction, you see how this acronym fits together. This is typical of a transmural MI, and we have 3 sequences. It is acute, we call evolving, or stable and chronic. So we really want to think about, I know this is all really confusing, but when you think about ischemia, it oftentimes happens through phases. And it's not necessarily like the chapter of a book where it just happens like a book chapter, but we can see different things transpire. So an acute, evolving, or stable, what we call an old MI. So an acute phase from immediate onset to a few days later, ST elevation in the affected area may resolve if someone has a stent. PTCA stands for an angioplasty stent. With or without stenting, occurred immediately after onset of an AMI as an acute myocardial infarction. and the Q wave may now be present. A Q wave is going to happen when someone has an MI, right? That negative deep Q wave, not just a little Q wave, but a pronounced Q wave is a sign that someone has had an MI. So evolving phase is a few days after that person has that MI, into a couple of weeks. A lot of times the ST segment is going to return back to baseline, but the Q wave just stays there. So interestingly, this entire semester I haven't really spoken much about the Q wave. So we all have a Q wave, but if the Q wave is really pronounced and deep, that's a sign that somebody's had an old MI, right? The other thing that can evolve is the T wave can invert. So we call that T wave inversion. With a stable or a chronic or an old heart attack, so someone who's got old damage, right? Because a heart attack and an infarction means cells died. So someone who survived a heart attack, they're going to have some dead cells, dead cardiac cells. And those dead cardiac cells can no longer contract. They don't have that contractility anymore. So on the EKG, the area is what we call electrically silent. It's not contracting, which is why it's going to have just those deep negative Q waves. So a few weeks after the MI, usually permanent ECG changes end up evolving. So we have Q waves in the STEMI, we have ST elevation that gets resolved. Sometimes the S wave may go beyond baseline, resulting in what we call QSR, typical of the right bundle branch block, which is that R prime pattern, and that T wave inversion can eventually be resolved. So if you have the textbook, the online version or the hard copy version, this is right out of the textbook. EKG changes in each phase of an ST segment elevation. So it's showing you, this is showing the location, right? So when you think back to an earlier lecture, I said we have 12 different photos of the heart giving us a different view of the different areas of the heart. And on this table, on the left column, it says anterior, inferior, lateral, and septal. Okay, so those are our different areas. And then it has the different leads we can be looking at. And those leads are where you were going to see either ST segment elevation, ST segment depression, or even just simply a pronounced Q wave. Right, these are the changes we see that evolve over time in myocardial infarction. So with an anterior, atypical MI, usually we're going to see a deep Q wave in leads 3 and 4. Anterior, front of the chest, those leads, those electrodes 3 and 4. In an inferior MI, which is kind of down by that left ventricle, we're going to be looking at leads 2 and 3 in AVF. So think about that nice circle I kept showing and talking to you about when we looked at axis. So leads 2, 3 in AVF. If we're looking at a lateral MI, those Q waves are going to be on the lateral side. That's lead 1, AVL. And sometimes our chest leads V5 and V6, the lateral side. Posterior MI, we are looking at Q waves in leads 2, 3 in AVF, and usually some really big looking R waves, which I haven't really spoke much about, but R waves in V1 and 2, the kind of the reciprocal lead. So this is a photo, which would be tricky for me to put a question like this on a test, but this would be a photo of, if I was to say, looking at this EKG, tell me where in the heart the infarction happened. And I give you a list of anterior, inferior, posterior, septal, and you're going to say, oh, this is an anterior MI, right? So why do I know this is an anterior MI? Let's go back, right? Anterior, Q waves in lead 3 and 4. So let's go back to our anterior, and then we're going to look at Q waves 3, V3 and V4, and we now begin to say, oh, okay, I begin to understand this. Here is a 12 lead showing a old infarction, right? So this old infarction, inferior infarction, which again are those those basically pronounced Q waves. Here's an EKG that's showing us lateral elevation, so you might think this is kind of evolving because the T wave inversions are evolving and changing. They're really what we look at, we call reciprocal, so leads 2, 3 in AVF. This would kind of be at the end of that acute stage. And then posterior infarction, right, that kind of reciprocal with the R waves. So ECG changes with infarction change depending on what's going on in the leads. So Q waves, what leads are they in, and then reciprocal changes with those leads. So here's another 12 lead that this one is showing us a septal infarction. So let's go back to what we talked about, septal, right? Q waves in leads 1 and 2, septal, right? In the middle of that chest, right where that sternum is, leads 1 and lead 2 with that septal wave. Here's an example of an inferior lateral infarction, right? So kind of looking at how evident that looks, and then looking at the anterior septal infarction in this figure. And here is both at the top an acute stage of an anterior lateral MI. The second photo is showing us the evolving phase of an anterior lateral, and then the old stage of what happens, kind of that standard old side. So treatment for a myocardial infarction needs to happen fast. Time is muscle. So within 60 to 90 minutes of onset of symptoms, significantly is going to decrease the damage. The more time that the person has angina or ischemia, the more muscle and cells are damaged. So you want intervention. You want to get back in the back of an ambulance, not in someone's backseat of their car. Get an ambulance. They can begin administering immediate care in an ambulance. That you cannot do that in your family car. You want to hope that you're a candidate for what we call thrombolytic therapy. It's kind of like, I don't know, but like liquid Drano for the heart, right? It's just clot busting, really potent medicine to help bust any kind of clots that are in there, any kind of thrombolytic activity. And then go in there into the cath lab, do a coronary heart catheterization with PTCA, percutaneous transluminal coronary angioplasty, either either just the balloon or the stent, to try to open up, to try to get that blood flow through. An aneurysm is ballooning of the blood vessel that could potentially rupture, so persistent ST elevation at the location of myocardial damage can lead to that. You can end up with pericarditis, inflammation of the pericardial sac. So ST elevation in all lymph leads except AVR and the chest leads is really classic for what we call pericarditis. So EKG changes seen with the aneurysm, pericarditis, and early repolarization are also important. So what we have here are what you see with the first column is your aneurysm, your pericarditis, your early repolarization. It shows you what happens with the ST segment. It will tell you kind of if there are reciprocal changes, what happens with the QR wave, what's going to happen with the PR segment, the QT interval. So all of these different areas of the EKG that we've spent the entire semester picking apart, now they all come together when we're looking at infarction, ischemia, and infarction. This is the photo showing us 12 lead EKG changes, somebody that has that aneurysm, as you saw. This is showing you pericarditis with inflammation. It looks like ST segment elevation, but it's not. This happens with pericarditis, that inflamed ST segment in all leads except AVR. And then diagnostic EKG criteria for exercise-induced myocardial ischemia. So what happens here is ST segment depression of 1 millimeter is measured after the QRS complex persists for about 2 minutes post-exercise. So they're done exercising and now it's persisting. They're in recovery, ST segment depression with or without T-wave inversions, as well as presence of the right bundle branch block. We also can see significant ST segment depression noted. Again, 2 to 4 minutes post-exercise, that's not present during exercise. So this is exercise-induced. They exercise and that pushes them into ischemia. And again, we're able to see that ST segment depression in those different leads into the recovery of the exercise test. So 12 lead EKG with ST segment depression, 1 millimeter in leads both. You look at 5 and 6, you see that. And after the QRS complex persisting into recovery, so they've already done their exercise test. Here is a tracing that shows you ST segment depression. Now the other thing we see in here is we see right bundle branch blocks as well, right? So now you're counting the width of your QRS to notice those right bundle branch blocks. You see them over on the right side. In the absence of a right bundle branch block or right ventricular hypertrophy, T-wave inversion, ST depression elevation with or without T-wave inversion can happen. You can also have marked ST segment depression of greater than 2 millimeters, usually associated with submyocardial injury. And we can have ST elevation with T-wave abnormalities. We call that kind of the fireman's hat configuration. And it can be with or without Q waves. So here is our 12 lead with T-wave inversion in the inferior leads. Here is a 12 lead with marked pronounced ST segment depression greater than 2 millimeters that happens with what we call submyocardial infarction. And we also, you notice the left ventricular hypertrophy that's in there as well. And then the last tracing, ECG changes with elevation and with as well as T-wave abnormalities. So the bottom line of this very gigantic conclusion to reading EKGs is really understanding ischemia and infarct, right? So ST elevation, ST depression, and knowing that the different leads when we're looking at a transmural MI, the ST elevation, depending on what leads, helps us to understand the location in the artery.